We have many providers that provide care in rural areas. They're not in suburban areas, they're not in urban areas. Will this impact them? Will it affect them the same way as it does all the physicians that are practicing in metropolitan areas?
That's a great question. And the short answer is it depends a little bit on the specific situation of those rural providers. Let me talk about critical access hospitals first. Critical access hospitals have two different billing methods, Method 1 billing and Method 2 billing. Those costs that use Method 1 billing are exempt from the payment provisions under the MACRA. Those that participate in Method 2 billing, and this is where the hospital has the ability to combine the billing for its clinicians as well as the billing that it does for its inpatient services. That actually depends on whether the physicians and other clinicians have reassigned their billing rights to the hospital. If they have, and they're billing under Method 2, then the MIPS actually does apply. However, for federally qualified health centers and for rural health clinics, the MIPS actually does not apply, and that's actually a statutory exclusion. The important thing to note here is that there are some subtle variations that depend a little bit on the particular billing situation that's being used by the particular rural provider. So let's say, for example, you have a provider that's working at a federally qualified health center and actually moonlights somewhere else where they're actually billing under the physician fee schedule. The portion of the services that they are providing and billing for under the billing system for federally qualified health centers, that actually is not subject to the MIPS at all. The services that they provide, however, under their kind of moonlighting arrangements, those actually could be subject to the MIPS. In addition, CMS will have to establish a minimum threshold below which the MIPS does not apply. So, for example, the MIPS may not apply if a clinician happens to bill for fewer than 100 Medicare patients and receives billing for less than $10,000 worth of Medicare services. That's a mechanism intended to recognize that not all clinicians have enough activity under the Medicare program to be scored in an accurate way.